This is the specialty clinic where patients are evaluated before surgery to establish which is another important advantage of pre-operative evaluation clinic is you will develop a good rapport with the patient. Earlier, anesthesia was considered as a behind the screen technician work or second fiddle to the surgeon. So patients, when I joined the Department of Anesthesia way back in 1975 at Chengalpet Medical College, the chief anesthetist was the only qualified person, and we 5 assistants were all MBBS graduates. So the assessment used to be done by the HOD, and he will there will be an adjacent room to the OT complex, and he will ask all the patients to come there with the case sheets, and he will make a cursory examination of the cardiovascular respiratory system and say you are fit for surgery, and just put a tick in the case sheet and put the signature and date and send the patient off. So this is how the whole system was going on. But after that, when I came to Stanley for my post-graduation, there was a specialist clinic like this. So we were posted there as a postgraduate for 1 month in what is called the pre-anesthetic assessment room. And it used to function between 12 noon to 2 p.m. and all the surgical units used to send their patients to that room with all the relevant investigations. We used to have a BP apparatus. We used to have a torchlight to open the mouth and see the oral cavity, the airway. And one senior consultant will be in charge, and 4 or 5 postgraduates will be posted along with him. And he will teach us how to do the evaluation and what are all the things that we have to look for in comorbid patients. If it is a diabetic case, how to evaluate. If it is hypertensive, how to evaluate. If it is a previous CAD case, how to evaluate. So teaching also will be done during that time. Okay? So that is how the whole system was operated way back in 1936 itself in the medical college side. So that system is still continuing, and that has been adapted in other colleges also, except some corporates where this sort of visiting the patient in their bed and then trying to assess is happening. Most of the other teaching institutions, they follow the pattern of having a pre-anesthetic checkup clinic where patients are all mobilized from the ward to the pre-anesthetic clinic and examined there and given the fitness. And as you rightly said, this will make the assessment easy process rather than the usual walking up to every ward, because patients will be scattered all over the hospital. So it makes easy to bring them all to one point and then try to assess them. And during that time, we can talk and develop a good rapport to them and explain to them what are all the benefits and disadvantages of getting the surgery done, and what is the advantage, disadvantage of the anesthetic technique that you are going to follow there. Okay, so the first thing is create a rapport with the patients and their families and allay the anxiety, because the common public, when they come for surgery, they always are little afraid. So by talking to them and convincing them about the safety of anesthesia and surgery, you can allay their anxiety. And by assessing the patient's condition, you can reduce the morbidity. For example, if you know that the patient has got a loose tooth, you can advise them to go and get it removed before surgery, so that there is no risk of the tooth getting dislodged and going and landing up in the airway and producing a problem. Or if you know that it is a short mandible with a thyromental distance reduced and you anticipate difficulty, you can alert the theatre anesthetist that it will be a difficult intubation, be prepared with the difficult airway part. So this way we can reduce the morbidity, and that way you can improve the quality of patient's care. And last minute delays and cancellation can be avoided by assessing the patient well in time, and then decrease the cost of pre-operative care also by assessing them as outpatient without admission, especially in daycare procedures, and reduce the shuffling of patients. As he said too, they need not be shuffled between the MRI, CT scan, and all these things. Everything they get done, and then they come to the assessment, so that everything is done under one place. And they can integrate coordinate the services of other people as well as for the admission, insurance authorization, lab testing, everything. And you can also get the medical consultation from other specialists also by incorporating them to come and see the patient in the outpatient clinic itself, and develop protocols, policies, and clear clinical pathways for quality assurance. Again, here it boils down to quality improvement here also, so that the patients will feel happy that they are not made to run around the various places of the hospital. And this will maximize efficiency in the operating room function and turnover time by knowing that these patients are already assessed and given the fitness. Now, where should this clinic should be located? It is preferable to be in easy access, mostly close to the main entrance, and it must be in the main outpatient department, OPD block, and preferably on the ground floor. Especially if you have a lot of geriatric cases, it is better to have it in the ground floor so that they may not climb stairs or come up in the lift and other things. And it should have the easy hospital to other diagnostic and support areas, and it should provide adequate space for the registration and reception, patient interview examination, patient and family preoperative education area, and there should be staff rest area, and it should also have a relaxed and private atmosphere for doing the pre-anesthetic evaluation and review of medical records and history examination. And you should discuss the risk and benefit of anesthesia option and pain management to the patient, because nowadays everybody asks, what are you going to do for the post-operative pain for me? So all these options can be discussed with the patient, and again alleviate the anxiety. And you can educate the patient as to what about the fasting time, what are the medications you have to continue. All these instructions can be given, and what is the anticipated hospital stay, transportation issues, all these things can be discussed at the time. And you can also validate the consent and documentation, reduce the delay in daycare surgery, and also have the telephonic calls made on the day before surgery. Now, what is the staff requirement if you have to have a separate pre-anesthetic clinic? You should have a specialist consultant who should be responsible for policy administration and quality assurance. And medical officers as well as trainees or postgraduates in anesthesia can be posted in the clinic as part of their training to ensure how to make a pre-anesthetic evaluation. And patients screen, the validation of that, once you assess the patient, unless the patient develops an acute illness, the fitness is valid for 2 to 30 days or more before the scheduled surgery. So you can do this thing well in advance. And the basic information about the patient, surgery plan, past medical and surgical history can be obtained by specially designed questionnaire. So instead of individually asking, you can allot a nurse or a trainee to have a preoperative checkup form in which you can fill up all the details, asking the questions to the patient, and make the available information much easily achieved got from the patient. And or sometimes you can ask the patient themselves to fill up. For example, you can have yes or no questions like, do you have hypertension? Do you have blood pressure? Do you have any angina problem? Like that, you can have yes, no, and then get the questionnaire filled up also. And then you can form a particular algorithm for preoperative evaluation. So assess the risk of surgery based on the nature of surgery, then assess the functional status of the patient, assess the stability of the patient, like assessing for shortness of breath, syncope, chest pain, then you can have the decision made on the basis of these three things: the nature of the surgery, the functional status, and the patient's physical status, fitness. And benefits and effectiveness: reduction in excessive preoperative testing, and then reduction in subspecialty consultants or consult trained. If the anesthetist is trained both in internal medicine and anesthesia, then it makes the life easy for the patient. You don't have to get an opinion from the diabetologist, you don't have to get an opinion from an endocrinologist or a neurosurgeon or a neurophysician. Individual consultations are not required if you are both an internal medicinist, a medicine intensivist, as well as an anesthetist. But our medico-legal problems do not accept this. That is the only thing which is preventing the anesthetist becoming an overall perioperative physician. Because once something goes wrong, the question that is asked in the court of law is, why did not you take the opinion of a cardiologist? Why did you not take the opinion from a diabetologist? So that question is still being asked. So that is the reason why this has not become a routine in our management of patients. And enhanced operative room functioning is there because of the pre-anesthetic checkup. And evaluation and daycare surgery, it's very, very important that most of the patients are assessed as OPD, and then it is valid for 1 to 3 days, the screening. And screen pre-operatively using several methods like the investigations, the physical examination, or these include questionnaires, telephone interviews, automated interviews, evaluation of pre-anesthesia, anti-pre-anesthesia available clinic. So as I told earlier, the personal visit of the patient is nowadays reducing if you belong to ASA 1 and 2 category by using the other methods of sending a questionnaire, getting their reply, or making a telephonic interview or a Zoom interview like that. And then telemedicine technology is being used here. So teleconferencing in the presence of an anesthetist is also used, especially patients who come from abroad. Nowadays, people are coming to India for treatment because it is much more cheaper compared to their country. So such patients are interviewed and then given the pre-anesthetic fitness and teleconferencing technology. And then once the fitness is decided, then they come to the country and get operated and go. So most limiting factor for implementation of a normal functioning pre-anesthetic clinic in all hospitals is lack of finance and shortage of trained personnel. These are the two deterrents for establishing a pre-anesthetic clinic in all the hospitals. One is financial shortage, second is shortage of trained personnel. So these are all the points I thought you should write for this particular question.